The shoulder joint is the most mobile joint in the body. The ball and socket configuration allows an extensive, nearly unlimited range of motion. This extreme flexibility comes at a cost, however. With limited bony interaction between the head of the humerus and the shallow cup of the scapular glenoid, the shoulder is prone to dislocation. Because of the anterior angulation of the glenoid, traumatic dislocations are usually anterior and inferior. Posterior dislocations are usually associated with clonic-tonic seizures, where the powerful muscles of the back pull the humerus posteriorly out of the glenoid fossa. While there are a multitude of muscles that act on and move the arm about the shoulder joint, 4 powerful muscles originating from the scapula and attaching to the proximal humerus are responsible for maintaining the glenohumeral articulation and are collectively known as the rotator cuff. Before we get into the details of the rotator cuff itself, let's review some relevant soft tissue and bony anatomy. Every skeletal muscle in the body consists of the contracting muscle belly with a tough but flexible fibrous band at the end known as a tendon. The tendons connect to the regional bony structures to both anchor the muscle and transmit the muscular force across the joint to move the bone on the other side. The scapula is a thick, flat, plate-like bone that's part of the upper extremity girdle and serves as a durable anchor for the powerful muscles of the rotator cuff. The scapular spine is an oblique horizontal projection or protuberance off the back side of the scapular plate that, again, serves as a sturdy anchor for the regional musculature. The acromion is a forward-projecting bony extension that articulates with the clavicle in front of the chest wall to provide anterior support of the scapula itself. And finally, the glenoid is the cup-like cavity or socket that holds the ball-like extension off of the head of the upper arm bone or humerus. There are 2 bony projections off of the humeral head called the greater and lesser tuberosity that serve as the strong bony attachments for the tendons of the rotator cuff. Remember, the rotator cuff is primarily responsible for securing the ball of the humeral head into the socket of the scapular glenoid fossa, and therefore there's no need to restore the bony thorax at this point, but we'll briefly display the thorax to clarify and recall the relationship and orientation of the scapula to the chest. The subscapularis muscle belly is affixed to the undersurface of the scapular blade, and the tendon passes under the coracoid process, then attaches to the lesser tuberosity of the humeral head. Its primary functions are internal rotation of the upper arm and stabilization of the shoulder joint. The remaining 3 structures of the rotator cuff originate from the back of the scapula. Beginning at the top, the relatively small muscle above the scapular spine is, appropriately, the supraspinatus. The tendon passes directly beneath the acromion and attaches to the greater tuberosity of the humeral head. Its primary functions are abduction or raising the arm, especially through the first 15 degrees of the arc, and stabilization of the shoulder joint. The infraspinatus is a large muscle originating from the infraspinatus fossa below the scapular spine and similarly attaching to the greater tuberosity. Its primary functions are lateral rotation of the upper arm and stabilization of the shoulder joint. The most inferior member of the cuff is the teres minor. Originating off the lateral border of the scapula, the tendon again attaches to the greater tuberosity. Its primary functions are similar to the infraspinatus, with lateral rotation and stabilization of the upper arm. These are the 4 muscles of the rotator cuff. Additional muscles secure the scapula to the thoracic cage and axial skeleton, including the serratus anterior, originating from the outer surface of the upper 8 or 9 ribs and inserting on the front of the scapula near its inner border. We'll now restore the humerus and the rotator cuff before we show the additional muscles that secure the scapula to the bony thorax. The rhomboids originate from the spinous processes of vertebrae C7 through T5 and insert on the medial border of the scapula. The latissimus dorsi muscle originates from the spinous processes of vertebrae T7 through S3, the inferior 3 to 4 ribs, the iliac crest, as well as a variable attachment to the inferior aspect of the scapula, and inserts on the intertubercular groove of the humerus. While the main action is to adduct or pull down the upper arm, it also keeps the tip of the scapula close to the rib cage. Finally, the trapezius originates from the spinous processes of vertebrae C7 through T12, as well as the occiput of the skull, and inserts on the scapular spine, acromion process, in the lateral third of the clavicle. Many other muscles of the shoulder work on the upper and lower arm that originate from either the bony thorax or the scapula. These include the triceps that extends the lower arm, the biceps muscle that flexes the lower arm, the pectoralis minor and major muscles that flex the upper arm forward, and the large deltoid muscle which raises the upper arm, especially beyond the 15-degree mark of the supraspinatus muscle as described previously. Looking back at the rotator cuff, of the four components, the supraspinatus muscle and tendon are situated the highest on the cuff, running in a tunnel bordered by the humeral head below and the acromion above. Repetitive motions, especially those involving over-the-head activities such as painting, carpentry, and pitching, can impinge on and damage the tendon over time. Thus, the supraspinatus is the most commonly affected tendon in rotator cuff injuries. In addition to job or activity-related risk factors, the anatomic shape of the acromion is felt to predispose certain individuals to rotator cuff injuries as well. Looking from the side, the acromion has three anatomic classifications. Type 1 is essentially flat, providing the maximum space for the supraspinatus and the lowest congenital risk for injury. Type 2 is curved with an intermediate risk, and Type 3 is hooked with the smallest space and therefore highest risk of injury. MRI can be used to evaluate the rotator cuff. Oblique coronal T2 weighted images through the supraspinatus tendon show a homogeneous dark signal if the tendon is completely intact. Areas of increased signal can represent fraying, partial tear, or inflammation, also known as tendinopathy, with a complete through-and-through hole in the tendon showing up as a disruption in the tendon itself. In the worst-case scenario, the tendon completely splits in half. The part connected to the muscle is pulled back towards the scapula. If the injury is chronic, the other powerful muscles of the shoulder will pull the humerus upward and fill the gap once occupied by the supraspinatus muscle and tendon. The loss of the acromiohumeral interval is described as a high-riding shoulder and is a plain film indicator of a chronic rotator cuff injury.